Hello, and thank you for joining me at Blood Cancers Today, ASH Roundtable. We're going to have a discussion focusing on MDS and anemia in lower risk MDS. I am Hana Safah, Professor of Clinical Medicine at Tulane School of Medicine, as well as the Director of Stem Cell Transplant and the Heme Malignancy Program at Tulane. Joining me are my colleagues.
Hi, I'm Jamile Shammo. I'm Professor of Medicine and Director of Bone Marrow Failure Program at Northwestern University.
Hi, I'm Andrew Brunner. I'm an assistant professor at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts.
Hi, I'm Tiffany Tanaka. I'm an associate professor for the Division of Blood and Marrow Transplant at UC San Diego Moores Cancer Center.
So because of the MEDALIST trial, Luspatercept was approved in 2020 for patients who have either failed or couldn't receive or were not expected to respond to epoprotin. And from there comes the COMMANDS trial. And the COMMANDS trial, the interim analysis was presented in ASCO last year. And it showed, again, the eligibility criteria was a little bit different from the MEDALIST trial. The patients there were patients who were treatment naive, so they have not seen the erythropoietin treatment before, and they could have RS positive, RS negative, although 75% of them were RS positive for reasons that we think we know why, but also they had to have erythropoietin of less than 500, and patients should have had a blast count of less than 5%. So when we look at the efficacy data, and the primary endpoint was looking at transfusion independence for 12 weeks, as well as combined with increase in the hemoglobin of 1.5 grams per deciliter within week 1 through week 24. And the data was significantly better in the Luspatercept arm compared to the erythropoietin arm, 60% compared to around 30%, and it was well tolerated and had a good outcome in all the subgroups. They showed that patients did better with Luspatercept, whether they are the mutated type SF3B1, the unmutated type, RS positive, EPO levels of less than 200 to 500. However, it was comparable between in the RS negative group to EPO. And we will have some discussions later to understand. Probably we have some explanations for that. Now what we're going to see in ASH now is the updated analysis or the full analysis on the COMMANDS trial with more time that has, looking at duration of treatment in the Luspatercept arm was around 51 weeks, and the EPO arm was around 37 weeks. And then we see with the extension of the period of time of treatment, the same results continue to be seen with 60%, almost 60% transfusion independence for 12 weeks with week 1 to week 24 in the Luspatercept arm compared to around 34% in the EPO arm. So again, there was significantly better results with the Luspatercept compared to the EPO. What also held is exactly the same sub-analysis that we saw earlier, that the improvement was seen in the SF3B1 positive patients as well as the wild, RS positive, the EPO level being less than 200 and 200 to 500. However, comparable results continue to be seen in the RS negative between the Luspatercept and the EPO. But again, when we look at safety, there was no increase in the safety signals. It was well tolerated, similar to what we saw in the interim analysis, hypertension, asthenia. So there was nothing that evolved with longer treatment and longer follow-up. So that's what we're going to see. And to me, as a physician who takes care of patients with MDS, again, the majority of those patients are with low-risk MDS and the anemia, and some of them are transfusion dependent. The question here comes, we're seeing improvement so we're gonna give a treatment that is every 3 weeks compared to weekly. That's gonna result with less transfusion dependence and more patients becoming transfusion independent, so less complications from transfusions. I'm hoping we're gonna discuss quality of life in one of the abstracts, but again, my colleagues always ask me, should it be only for patients who are transfusion dependent? The FDA gave it the approval recently for patients who are transfusion dependent, as well as might be or could be. And I think that's an important point, and we should not take it lightly. Maybe we should talk about when should we start such treatment? Should we wait until they become transfusion dependent? And again, there is abstracts that is showing maybe it is better to start it early on to prevent the transfusion dependency and the complications that come with that.